Hi, everyone. I'm Ahmad Amin, one of the cardiology fellows at Mayo Clinic, Rochester. And today at ACC 2025 in Chicago, I have the privilege of talking to Dr. Frank Selke. Dr. Frank Selke is the Chief of Cardiovascular Research, also Chief of Cardiothoracic Surgery at Brown University. He's holding all the chief positions at American Heart Association, also many cardiovascular thoracic surgery communities. It's my pleasure, Dr. Selke. Thank you very much for accepting our interview invitation. To start, I want to ask you about the structural heart disease intervention. This is something at the frontier of clinical practice and research. Where do you think this field is heading in like 5 to 10 years from now?
Well, I was involved with the structural heart development from the very beginning, from the initial valve placements by Dr. Cribier and Ron France, and the results were rather marginal. But even at that time, I saw that this was going to be the future of treating valvular disease. I'm involved doing this about 3 days a week. It's very effective. There's still some issues with tricuspid and mitral repair. We have the mitral clip procedure, but there's new devices being developed. So I think in 5 years, we're going to be doing even more TAVR procedures, transcatheter aortic valve replacements. Currently, we're doing about 80% TAVR, 20% regular surgical valve replacements. I think it's even going to go further, probably 90%. I think there's going to be further development of tricuspid and mitral valve replacements. So it's that even going to go further to supplant the traditional cardiac surgery. So like it or not, this is the way things are going.
This is outstanding. Thank you very much for that. So based on that, I actually want to have my main question, and that's what advice can you give to trainees in cardiology, interventional cardiology, and also cardiovascular surgery who are interested to get involved in this field?
Well, first, I think getting excellent training when you're in the beginning is critically important, and perhaps getting some additional training in a subspecialty, whether it's aortic surgery or heart failure or valve repair, something like that's beneficial, and working on the fringes of your specialty. For example, clinical surgery or clinical cardiology and research or clinical trials. That really sets you apart from others. So if you want to advance your academic career, I think it's almost necessary to do something like that.
That is fantastic. I think my next question would be, what is your advice to programs who want to have a successful structural heart disease in terms of how cardiology and cardiovascular surgery should collaborate? What infrastructure should they have? Do you really think having registries help a lot? Do you think we kind of should have a multi-modality imager plus a heart failure, plus a general cardiologist sitting together? Like, what's the role of the heart team there? And like in just short, what is the key to success for a structural heart program?
Well, first of all, I think you need excellent clinicians in all the specialties, cardiovascular surgery, cardiology, interventional cardiology, imaging. You have to have excellent clinical practitioners in these areas. And you have to have a collaborative approach. You have to have weekly meetings, weekly clinics in which all specialties get together. I have to have a hybrid operating room where you can do both cardiac catheterizations, the TAVR procedure, the mitral clip procedures, and traditional open heart surgery, because occasionally things don't go so well. You have to be prepared to do those things. But most important is a collaborative approach between the different specialties, and that's of critical importance. The heart team approach, as it's usually called, you actually have to have an actual collaborative approach where you have mutual respect from the different specialties, not just, okay, you talk about it and then one person does what he wants. No, it actually has to be a collaborative approach where you have mutual respect and come to some decision on the best treatment for the patients.
That was fantastic. Thank you very much for that word of wisdom. And before finishing up, do you have any general recommendation for us, trainees in cardiology, trainees in cardiovascular science? What are your words of wisdom for us?
Well, again, I think getting excellent training and getting some subspecialty training to supplement the usual procedures that you perform. Again, try to get on the fringe of another area. Could be clinical trials, outcome research, rheumatology and cardiovascular disease, oncology and cardiovascular disease. I do a lot of research, and that's been a great part of my career for the last 40 years. It really sets you apart, and it gets you noticed at national organizations. So if you want an academic career, I think that's the way you should go. And there's nothing wrong with being a traditional clinical cardiovascular specialist. If you're not interested in research and presenting at meetings, I think just getting excellent clinical training and taking a collaborative approach with your colleagues.
That was fantastic. Thank you very much for the opportunity to talk to us, and thank you very much for being with us in this talk. For more videos like this, check out our channel at YouTube/FITsOnTheGo. Thank you.